Hitting a wall with your knee replacement motion is incredibly frustrating. And if you're watching this, you probably know exactly what that feels like. You're doing the exercises as hard as you can, but you just aren't seeing progress. The truth is, there are proven strategies for improving motion, but there is one factor that determines exactly which strategies may help the most. And that factor is timing. The amount of time that's passed since your surgery is what determines what can actually help your motion and what may just waste your time. I'm Dr. B, and I'm a Harvard-trained, board-certified orthopedic surgeon who specializes in hip and knee replacements. In this video, I'll walk you through the 3 motion phases after surgery and the proven ways to break through plateaus in each one. Each phase after surgery has its own strategies that work best to break through motion plateaus. You can think of each phase and its strategies as a rung on a ladder. The further along you are, the higher you have to climb, and the more involved the strategies become. The first rung covers the first 6 weeks after surgery, and the most powerful strategies in this phase are making the most out of your physical therapy and controlling the inflammation in your knee. Everyone knows that physical therapy is important, but the truth is, not all physical therapy is the same. There are at least 3 crucial ingredients that make physical therapy improve motion. The first ingredient is a strength-focused approach. This means that exercise is used to expose your muscles to more and more stress over time. For example, the first week you do an exercise, you may use a 20-pound weight. The next week, you go up to 25 pounds, and the week after that, you go up to 30 pounds. There are all sorts of exercises that can be used for strength training, but some common ones are the leg press, leg extension, and leg curl. Now, this doesn't mean that you have to become a bodybuilder, but it makes sense that strengthening the muscles would lead to better range of motion. The muscles around the knee are what make the knee move, so by forcing the muscles to become stronger with these exercises, the muscles become more effective at moving the knee through its full range of motion. But strength isn't the whole picture. No matter how strong the muscles are, movement can still suffer if the muscles don't work in a coordinated way. You can think of it like attaching a race car engine to a tricycle. You would have so much power, and so little way to control it. And, of course, the results would be disastrous. That's why the second ingredient for effective physical therapy is neuromuscular training. It sounds complicated, but you can think of neuromuscular training as practicing how your muscles work together. That includes working on balance, coordination, and stability. All of these help your brain move your knee as effectively as possible. In order to bend and straighten your knee, your brain sends signals down your spinal cord and into the nerves that attach to your muscles like electrical wires. Strength training builds up the muscles at the end of that chain, but neuromuscular training improves the whole chain, from the brain to the spinal cord to the nerves to the muscles themselves. It's a more holistic approach. So, what does this mean in practice? Exercises like the single leg balance, pelvic bridge, and chair squat all help to improve the interaction between the nerves and the muscles. And there are many more exercises that your physical therapist can help guide you on. But while strength-focused therapy and neuromuscular training are both effective at breaking through motion plateaus, the reality is that they can both be useless if the third ingredient is ignored. And that ingredient, just like the theme of motion as a whole, is timing. As soon as the knee replacement surgery is over, the healing process begins, and scar tissue starts to form inside the knee joint. You can think of it like wet cement that slowly hardens over time. As weeks go by after surgery, that cement gets harder and harder until it's fully set. As that happens, your knee's motion becomes more and more difficult to get back. The first 6 weeks in particular are so important, and that's why starting physical therapy early matters so much. The goal is to get as much motion as possible before that scar tissue, or cement, has fully set. But here's the truth that every patient should know. There is one factor that has consistently been shown to increase the amount of scar tissue that grows in the knee. That factor is inflammation, and that's exactly why the other powerful way to break through motion plateaus in this phase is to control the inflammation in your knee. So, how do you actually do that? The first method is to use cold therapy the right way. There are a lot of options out there, but they fall into 3 main categories, and they each have their important differences. The first and simplest is ice packs. They're inexpensive, but some people find them inconvenient because they need to be constantly refrozen or refilled. The next category is continuous cold therapy devices, sometimes called ice machines. These circulate cold water through a pad that wraps around your knee. They stay cold for much longer than ice packs do, but they often aren't covered by insurance. The last category, cryocompression, is a bit different. These combine that same cold water circulation with gentle, intermittent squeezing to push fluid away from the knee and reduce swelling. That combination of cold and compression may actually improve range of motion faster than cold alone, but these devices are also the most expensive. Now, here's the reassuring part. Regardless of which category you choose, studies show that cold therapy helps improve range of motion early after surgery. There's no perfect protocol, but there are two strategies that seem to make cold therapy especially helpful for motion. The first is prioritizing using it before and after physical therapy to help reduce the inflammation from exercise. And the second is starting it early, ideally right after surgery. Just remember to follow your own surgeon's protocol, since the best approach can differ a bit from person to person. Now, as helpful as cold therapy is, it isn't the only way to control inflammation. The other way, like the name suggests, is with anti-inflammatory medications, also called NSAIDs. Because inflammation is linked to more scar tissue formation, these medications may help prevent stiff scar tissue from forming inside the knee. In fact, studies show that anti-inflammatories like celecoxib are linked to better range of motion early on after surgery. But an important thing to remember is that, like all medications, there are some downsides. They can cause side effects on the heart, the kidneys, and the stomach. And some patients can't take them at all because of their medical conditions or other medications they're taking. So if you're interested in trying anti-inflammatories, talk to your surgical team to see if you're a candidate. The bottom line is that weeks 0 to 6 aren't just about fighting your knee with physical therapy. They're also about calming it down. But beyond week 6, the scar tissue gets harder and starts to set in the knee like cement. And I'll be honest with you, the more time that has passed since surgery, the less those first rung strategies can do to break through big motion plateaus. That makes the 6 to 12 week rung a critical inflection point that many patients don't even know about. Everything from the first rung is still important here, but two new strategies enter the picture to help fight off scar tissue before it's too late. Those strategies are static progressive splints and manipulation under anesthesia. A static progressive splint is kind of like a brace for your knee. You strap it around your thigh and your calf, but the key feature is a knob. As you turn the knob, it gently pushes your knee further into a stretch and locks it there. This lets you hold your knee in a deeper stretch than you could ever hold on your own, which causes the tight tissues in your knee to slowly relax and lengthen. It's kind of like a stiff rubber band. It may not stretch far at first, but if you pull it as far as it can go and hold it there for a long time, the rubber band develops slack and becomes longer. Now, if you haven't heard about these splints before, this process may sound a little like torture, but in reality, most protocols recommend using the splint to get a gentle stretch, not pain. Studies show that patients can improve their motion by about 20 to 30 degrees with the help of these splints. That's a significant improvement, and it may be worth talking with your surgeon about. But here's the catch. Most protocols recommend using the splint a few times every day for several weeks. And the reality is that not everyone has the time or the desire to keep that up. The other strategy on this rung takes a very different approach, and that is a procedure called manipulation under anesthesia, or MUA. An MUA is an outpatient procedure where you are sedated and your surgeon slowly but firmly bends and straightens your knee, breaking up the scar tissue in the process. Going back to our cement analogy, your surgeon is basically stirring the cement to prevent it from setting and buy you some time. But that's the key point that everyone should know. It buys you time. It doesn't just automatically get you to your motion goal. In fact, it's normal to temporarily lose some motion right after the procedure because of the inflammation that it causes. For example, if your surgeon bent your knee to 120 degrees during the procedure, you might wake up being able to only bend it to 90, and from there you have to work to win that motion back. That means to get the most out of an MUA, it's crucial to make the most out of the first rung strategies of physical therapy and inflammation control after the procedure. The good news is that MUA works. Studies often show an average long-term motion improvement of about 30 to 35 degrees. But as we move beyond 12 weeks and into the third rung of the ladder, the story starts to change. The scar tissue has reached a critical hardening point. The strategies from the last rung still work, but likely not as well. Static progressive splints can still help, but we don't have much data on how effective they are this late. Where we do have strong data, though, is with manipulation under anesthesia. After 12 weeks, MUA becomes less effective at breaking up that stronger scar tissue. The procedure can still be done, but a late MUA often only gives back about 1/2 to 2/3 the motion that an early one would have. And to add to the problem, MUA done more than 12 weeks after surgery is linked to a higher risk of complications like fracture and a higher risk of needing more surgery done on the knee. That's why I called the 6 to 12 week phase a critical inflection point earlier. Once 12 weeks have passed, the powerful MUA option becomes less effective, and more invasive options may need to be considered to break through motion plateaus. That's exactly why the first strategy on the third rung combines manipulation under anesthesia with a surgery that cuts out the scar tissue directly. That surgery is called lysis of adhesions. It has a complicated name, like everything else in medicine, but the idea behind it is simple. A surgeon goes into the knee, usually with a minimally invasive technique called arthroscopy, and uses small tools to cut the scar tissue. Then the surgeon usually performs a manipulation under anesthesia to finish breaking up anything that couldn't be cut away. Patients often gain about 25 to 35 degrees from this combo procedure. Now, like with any surgery, there is some risk. Because the surgery involves going back into the knee joint, infection risk is higher than it is for MUA alone. But as powerful as it is, lysis of adhesions and manipulation under anesthesia sometimes isn't enough to break through the motion plateau. This is especially true when the scar tissue has grown completely out of control or when the lack of motion comes from the improper positioning of the implant. That's why the last resort on this rung is revision total knee arthroplasty. This is a term for surgeries that involve changing the parts of the knee replacement implant. Sometimes that means just changing the plastic liner in the center of the implant, which is usually a straightforward surgery, but it can also mean removing the whole implant and putting in an entirely new one. Which approach your surgeon takes depends on what's causing the lack of motion. Studies show that these surgeries improve motion by about 20 to 30 degrees on average. That's a real gain, but here's the thing. The starting point is often so poor that even a big improvement often only lands the final motion at about 90 to 100 degrees. And of course, if the revision requires removing all the implants, the surgical risks are greater, and the recovery is longer. So here's the bottom line. Revision surgery is sometimes the only realistic way to break through a motion plateau, either because everything else has failed, or because the range of motion limitations come from the implant's position. Just know that it's the most invasive option there is, so talk to your surgeon about what they expect your recovery to look like. This is a lot to take in all at once, so let's do a quick recap of each rung and the strategies to beat motion plateaus in each one. The first rung covers the first 6 weeks after surgery and includes making the most out of your physical therapy and controlling the inflammation in your knee. The second rung covers weeks 6 to 12 and adds static progressive splints and manipulation under anesthesia on top of those first rung strategies. The third rung covers everything after 12 weeks and adds lysis of adhesions with manipulation under anesthesia and revision total knee arthroplasty on top of everything below it. I hope this gives you a clearer idea of what can beat a knee replacement motion plateau. Keep in mind that this is a simplified picture, and there are lots of variables that make your situation unique. So, as always, the best person to talk with about these options is your orthopedic surgeon, who knows you and your situation the best. If you'd like to know my top 8 exercises to maximize motion in the first 6 weeks after knee replacement, I'll put my video on that right here. And if you want to know what motion numbers you need in order to do things like get up from a chair or climb stairs, this video covers it all. If you found this helpful, click the like button and consider subscribing for more knee replacement education. Stay well, and I'll see you in the next video.